Check. Check, 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 check. No.
Tags off.
The main fader.
For those of you joining the Intermountain IUH session, if you could kind of work yourself to the middle here, we'll probably have about a third to a half of the attendees here. So if we could not be too spread out, it'd probably be nice. So kind of more in the middle first, that'd be appreciated.
Okay, good. Because otherwise, Bob has to talk for 20 minutes of dead air. Right.
Okay, I'm in charge of the roundabout.
Do you want me to slip that in the pocket?
Yeah. Yeah, if you've got an inside pocket, then I'll try.
Sure. I'll put my phone on the other side to balance out the way. And I shouldn't wear my name tag, I take it.
We can hear you.
So you can go ahead and check in the room if you need to.
Oh, we are happy to keep talking.
Okay, we're good. We can mute him. Now, if check 1 2, check 1 2, check 1 2. No, yeah, they're typing right now, making sure you can hear us. Perfect. Okay, great. So this is what you guys will see. And when you'll also see your slides when you share your slide deck. And then we will share, as far as I'm aware, let me know at any time if I'm wrong. We have 2 different slide decks. We have the Intermountain one and then we have yours, right? Or is it all one? Okay, great. So, and who's going first? You guys or Intermountain? Intermountain? Yes? Okay, great. I will wait. We were told Intermountain first. Okay, great. Yeah, I'm the tech person, so I'm a little bit out of the loop on everything like that. But that's great. So we'll share, and then when Intermountain is done, we'll hand it over to you guys to share. If at any point, okay, perfect. If at any point we have any tech issues or anything, I'll be on hand to help that. And so,
There's 2 of them, and they both do the same thing.
sorry, there's a lot of people around me. Okay, so Intermountain is going first, which means you'll share your slide deck first, okay? Sounds great. We'll stay muted until it's ready. Perfect. And then if at any time there's a problem, I'll be around, and I will be monitoring the chat to help you guys if you have any questions or anything.
There we go. Good morning. Welcome to this session around peer guidance. Good to have all of you back from various rooms. This probably represents about a third to maybe a little more than a third of the people here. So if you want to move to the middle, you can. It's probably not going to get a lot bigger than we've got right now, but I think we can handle you where you are too. So thank you for being here. I'm Bob Cash with class, and we'll be at least kicking off this conversation today. I will mention now that we do have two groups presenting, representatives who are on the stage from Intermountain Health, and we have individuals from Indiana University Health who will be joining remotely to share some of their experience. So there is a technical component to this one that we haven't done yet at this summit today. We've done it before, but not today, so hopefully that'll come together as we have planned. We have a few minutes while this is happening to make sure that that's ready. So I'm going to just introduce the concept of peer guidance for just a minute, introduce the participants or the presenters, and then turn it over to Jason here in a second. So let me just tell you a little bit about peer guidance as soon as my slide comes up. So what is peer guidance? It was introduced at the 2019 Learning Summit. I am curious, I know we asked this morning, but how many were here in 2019? Just if you're, okay, a few of you. And Taylor Davis actually presented the concept and said, we've got a lot of you who have had great experience, been successful in the work that you're doing, and we think that we could help others by bringing them to you, learning more about your organization. So we end up, when we've done this, and I'll talk about how many times we've done this by bringing together some of those experts, taking them to your organization, learning about your organization, and then coming back with some recommendations. So you can see the typical agenda. We review your organization, your needs, your plans. Then we share, we get learning from key stakeholders that you can bring in that might be able to share what the experience is like with your electronic health record. We do rounding. The rounding is probably one of the most exciting and interesting parts of peer guidance, where we really learn from the people on the ground that the things we just heard actually are true, or maybe they're not. And so it actually is a really good experience to do that. And then those peers bring back, along with class and our understanding of multiple organizations, some recommendations for the organization. So that's the concept. So activity. So that was 2019. If you recall, we've said this several times, something happened right after 2019. So our first peer engagement was in December of 2019. It was with Intermountain Health. It was actually Intermountain Health Care at the time. It's now Intermountain Health. And we had a great engagement there that they'll talk about. Then we had COVID. Not much happened for a while. And then in this last year, we've had a couple of other engagements that have been really exciting. One in Australia, eHealth New South Wales, and one at Indiana University Health, which they will be sharing a little bit later. So we'll be learning about both of those in just a minute. But let me just introduce who we have here now, and I'll just introduce the Intermountain folks, and then we'll introduce the IUH folks when we get to that. We have presenting to you today Dr. Doug Nelson. Doug is the Medical Director of Informatics at Intermountain Health, a fun guy, a pediatric ER physician, and a bundle of energy. Then we have Jason McClellan. Actually, these guys are all bundles of energy. But anyway, Jason also an excellent expert on informatics. He is an informatics leader at Intermountain, has served in multiple roles, including most recently as the interim CNIO, for lack of a better term, and but is now very involved in all their informatics process. And then Chris Gorley. Chris is responsible for training in the informatics department at Intermountain Health. And so I could say more. I'll just say this. These guys I consider my friends, good people who are trying to do the right thing for their clinicians. They care, and I think you'll see that in their presentation. So I'll turn the time over to Jason.
You have to give that. Oh, you don't? No, I need that. I'm going to need this to advance the slides. We talked about it earlier. My name's Jason McClellan. Thank you for introducing us. I'm going to be talking a little bit today about, it's sort of a condensed version of a presentation we gave a couple of years ago about how terrible our EHR scores were. And then what we did about it and how peer guidance was integral for us to understand that the plans that we had were going to work and which ones we hadn't thought of and which ones were really bad ideas. And then how we've learned from that and we're going to be paying it forward. So this is the obligatory a little bit about us. This is our footprint, 33 hospitals, shy of 400 clinics. It's quite a large space. When I'm talking about the EHR experience scores, I'm really going to be talking about those down the middle in our Cerner area. It's where most of our hospitals and clinics lie. It's the largest portion. If we ever happen to say DTS, we're talking about digital technology services, and that's us, and we administer to all of these regions. So a little bit of background before I show you the scores. We were migrating from a homegrown EHR that we had that was beloved by our clinicians. Are you losing me? I feel like I'm losing myself. It was called Tandem helped too, and but it didn't have any CPOE. Moving to that period of 2015 to 2017. And as part of that implementation, we were really focused on training. We thought we knew what we were doing, and we focused a lot on implementation and classroom training. We did not think a lot about how we were going to train new caregivers after that, and we did not think a lot about how we were going to do ongoing training programs. We did not think at all about mastery or coaching. Those didn't, I mean, probably somebody thought about them, but we weren't focused on them nearly enough. What we were aiming to do was create the EHR of the future, so we were going to make lots of enhancements. We were going to put so many cool things in there, and it was going to be amazing, and everyone was going to love it. And we neglected stability, pace of change, implementation principles, and, as I mentioned, mastery. And we weren't measuring satisfaction at the time, and we ended up being outliers in the most fabulous way. We were not the outliers we wanted to be. So it wasn't a surprise to us before we got these scores that the EHR experience was really, really poor. We heard it all the time. I had a couple of slides in another presentation about kill it, start over again. It's the worst thing anyone's ever done to Intermountain, those sorts of things. It was widespread and obvious, and it was so important that the Intermountain board, it was among the top things that they were focused on because we were in the 1 percentile, and that's not the sort of outlier we wanted to be. It was a tornado chart causing a tornado of what are we going to do about this? And a lot of organizations have had this slide. I have it too. You can see in the background all the things we're proud of among those things, and then like right over the top, this thing that we're not so proud of, and how we're going to come to terms with that and accept it and understand what we're going to do better. How is it that we're a HIMSS Level 7 organization? How is it that we win Davies Awards, but we fail our clinicians with the EHR experience? In a way, and that's not at all like what Adam's slide was about his family. I would have loved to have that slide as our experience score, but it was not that at all. But in a way, that was a blessing for us because we didn't have a problem that many of your organizations probably have a problem with, which is that the scores are not great, but they don't get the sort of attention that they deserve, and it's hard to get traction and to get buy-in. We were blessed with having lots of buy-in because it was unacceptable at a very fundamental level. So that helped us foster a really humble approach to, oh, yes, of course we're not doing this right, and we need to do it better. How are we going to do that? And I don't know if this is like an academic way to approach this, but I just sort of broke down. You got to collect it, and you sort of have to believe it. You have to accept it, that it's real. Do your processing, planning, brainstorming, and then there's this important one here, this get advice. Getting advice, and sometimes for you that might be, oh, I have a friend at this other health system who's going through something similar. I have this network I'm building. We're going to talk a little bit about how going beyond that can be really powerful, going beyond the friends. And then you need to plan more, and then you need to act. And that's perhaps to contrast it with what we see even within our own organization. When I was showing the footprint, we have 3 general regions with a variety of EHRs. Sometimes we say the number's 5, and sometimes we say the number's 8, but there's a lot. And we've surveyed, I think, 9 times with class. And for some of those, it's hard to accept the score and to believe. So the opposite is to doubt that the meaning of the results are what they really mean, and to want to stay the course, to think that your problems are unique and nobody else has them, and to spin it, to say, well, that's not really what that means, it means this. And then just to keep doing what it was that you were doing. And if you're going to do that anyway, you don't need the data. So how do you How do you think about it differently? Well, this is maybe overstating the point, but believing it's real, processing it emotionally, so you can actually get to the planning part. Can we get to what is it that we're going to do? And once we get to what we're going to do, what do we focus on? When? When do we start doing this? What order? How much do we plan before we start sprinting? How do we allocate all the limited resources that we have? When should we measure again? On and on and on and on. And we certainly had a lot of ambitious ideas, and we were committed to solving this, but we didn't really have an outsider perspective as to whether or not these challenges that were sort of new to us had already been solved by someone else. Connor, I think, said it well in the welcome speech. He said, oh, I don't know, something about you have friends who have been there before. We wanted somebody to talk to us who had been on observation point, that there was an easier path to get to that place, and we didn't have to climb Angel's Landing and fall off the cliff on the way there, maybe, or risk falling off the cliff. So, with that in mind, transitioning to this concept of peer guidance and the value that that can offer you as an organization. And I'll turn that over to Chris.
Thanks, Jason, for the, there we go. Thanks, Jason, for the overview. Anytime we do this presentation, or talk about this experience with other organizations, seriously, I have PTSD, like my hands start sweating, and I feel this churn of when we were rounding and doing site visits and reading all the class comments from our first measurement and thinking that class could open up a new arm of the organization for like recovering organizations and offer therapy. So if I'm shaking and nervous and sweating, it's not presenting, it's reliving 2019 and those experiences. But we were lucky to be the first participant of the peer guidance, where we were able to spend 2 full days with 4 amazing organizations and very talented leaders from Kaiser, Memorial, Sharp, and UCLA Health, to have in-depth discussions about, what direction do we really go? We had Excel sheet on Excel sheet, and consultants and the board and physician leaders and everyone telling us kind of what to do. And to wrap our arms around that into a plan of deliverables was completely overwhelming at the time. And then they said, well, now we're going to bring in 4 organizations to critique all this and give you feedback. And that made us even feel a little bit more overwhelmed. And I remember going into this peer guidance thinking, this is going to be interesting, to really pull back the curtains and allow these amazing leaders to look at what's going on, and was completely nervous going into that. But it ended up being really an overall big relief to sit with individuals and leaders in healthcare that are in your shoes, that are facing the same challenges, that have gone through your challenges, and to show them all this information coming out at you and have them help you put together a really specific plan, a concrete plan of action items that have been tested and proven and that will work. We weren't getting a lot of new resources. We got no new resources. And so we couldn't waste our time. We couldn't waste our resources on deliverables that weren't going to put out results. And so having them in the room made such a big difference and was truly a big relief. And really, from that meeting, we were able to come, like I said, to put together a very simple plan. In nature, obviously, each one of these had a lot of work and effort into them. But start focusing on people, not the code. Make stability and response time a top priority, so close partnership with our app delivery team members. Improve communication. Develop effective coaches that can do really good training and optimization training and invest a lot of time in developing those coaches. Centralize EHR training, and then launch mastery program. Stop focusing on those enhancements, on frequent changes, rounding without a specific purpose, and honestly, not much that we had to continue besides being humble. And that's where this peer guidance really helped us get out of the gate with that very specific plan, and really elevated our confidence in those plans that we were developing. Like I said, it's one thing to hear from a consulting organization or even from class, but hearing directly from those that are in the weeds with you, going through it, and what's been effective makes such a big difference. So I'll just focus quickly on 3 really deliverables around our centralizing new hire training, some of the outcomes with that, improving end user communication, and then our one-on-one coaching program. So centralizing new hire training coming out of implementation, our new hire training was really delivered a lot on the unit or some fragmented experience. And so we started bringing together and putting together this centralized training program. And you can see on the left here, it's my left. Yeah, your left as well. Okay, that works out nice. That we're both looking on the same side of slides. That makes sense. Now that I've run that. Unfortunately, it was in a presentation. But the quality vendor, we use the quality trainer quality benchmark, which is our smile sheet. Did people appreciate the training? Was the trainer an effective communicator? Those are smile things. It's nice. Sometimes you can hand out candy bars if people are happy with the training, right? So that's a good indicator. But most recently, we evaluated really what's the net EHR experience of the nurses that are going through this centralized training compared to their peers. And we were amazed at these results that just recently came on. This is fresh out of off the press here of our ambulatory nurses that were at 7 and now at 52 when they've gone through our centralized training program, and 21 compared to 61 for those that were getting on-unit or go-live training. Obviously, there's a lot of factors that play into that. It's not just the training, but the fact that we had a group of nurses that were above the Arch Collaborative average, something that we couldn't even have dreamt of back in 2019, and having that type of experience on our system was something we're really excited about. And lots of great comments around the program overall and that training and getting into production, helping them be set up for their first day in the hospital or clinic. And then we improved the communication. I remember sitting down with Kaiser and actually them pulling up their communication template, them showing us all the details and what it could look like and how to send out that communication, how it could be targeted, how to format it, how to get it to be read, all of those types of things. And then finally, one of our big products that we've presented a lot on is that one-on-one coaching program where we use internal coaches from our training team, not physicians, not a lot are clinicians, nurses, and therapists and things, but actually no physicians. And we provide one-on-one coaching on an ad hoc basis. It's tailored to meet those individual needs. We've surveyed a lot along the way to make sure this had the return on investment and made it as easy as possible for clinicians to sign up and participate. Before those sessions, we do a lot of research. Our coaches spend tons of time. Now they're getting a lot more efficient at this. But we'll review the objective data. They'll even watch the film. We can have a session recorder where we watch where clinicians are clicking through and then create an individualized, lesson plan for that individual at a time that they want to meet, where they want to meet, virtual, in person, that type of thing. And then as a result, going on to our next slide that just shows some of the results from this, the coaching. And this is one of my favorite examples. Our pediatric hospital, they were so committed to this and so dire, and their medical director felt so passionate about training and coaching. They said, hey, we want every physician in APP in our entire hospital to go through coaching. And halfway through that project, we had a full class survey as a coincidence. So we pulled out everyone who participated in coaching and those who had not participated in coaching, and these were the results, the comparison. And so you can see a 34-point difference in the overall experience between those that had done coaching and those. That was the only difference. And that N is not the number of participants. That's actually the certain organizations that we were comparing to with the percentiles. The N was higher than that, but. So really impressed with that. And then overall was everything that we were doing around response time and reliability, improving communication, slowing down changes, making sure, centralizing new hire training, launching mastery, was it making a difference? And we saw from our first survey to our second survey that 34-point improvement. And now we're seeing, even higher improvements with these groups that are experiencing that full experience with onboarding and ongoing training. So super excited about that. And once again, it really ties back to that peer guidance and pulling that together into a concrete plan. And Doug's going to talk about the end of that and then our opportunity to share with others.
Thanks, Chris.
Yep.
Which, it's the big green
Big green button.
Okay. Just didn't want to hit the ejection button or something, fly up. So, as Bob mentioned, we were the first patient to go through the peer guidance program, and then COVID happened. And so we had a few years of putting into place many of the interventions that stemmed from our peer guidance visit. And Mike and Kathy from Kaiser Permanente are here. They helped us achieve some of those results that Chris just showed you on that slide. And so we continued to work on improving scores. And last year, class gave us a buzz and said, hey, we're thinking of starting up the peer guidance program again now that we can meet with people in person. Does Intermountain want to, do you guys want to participate? And we're like, us? Do you know what our scores were? Are you bringing us along to just carry luggage for Kaiser Permanente? But they said, no, you did have some of the world's worst scores. But you really appear to have benefited greatly from the peer guidance visit, and we were in total agreement with this. So it's been an honor and a privilege to be the only healthcare system of the 150 in the Arch Collaborative to now go to be on both sides of this peer guidance visit. And I can say from experience, it's more fun being the peer provider than the patient with the low score disease. But it's been a fabulous learning experience in a way that's different and distinct from our regular jobs that we do with Intermountain. And it really has let us pay it forward and try to help people the way we were helped, and that helped us do our jobs better. So being a peer guide, so far we've had the experience of working with both domestic US and international systems, governmental, non-governmental, and it's sort of like on a much larger scale what one of Chris's coaches does before they meet a provider like me to give me mastery coaching, right? Someone's looking at how I use the EHR before they meet with me for 60 minutes, which, as Chris showed, produces a phenomenal increase in EHR satisfaction. Well, before we, and it's not just Intermountain, right? We're with other higher performing healthcare systems visiting a system that's asked for our help. We crunch a lot of data. We look through the data, an enormous amount of data, then we ask questions and class gets us more data. And of course, it's actually pretty easy to look at the format of the data because we're used to the tornado graph. We're used to the, oh no, too much orange, we want green graph. So that's very helpful. But you can't get the total picture of what's going on the ground just from the data, and that's where the visit really helps. And the visit occurs, the two main chunks that we do on site are both the discussions around tables and the rounding. One of our takeaways, which will not come as a huge surprise, is that we are all far more alike than different. Whether you are a governmental system in Australia, an academic system in the United States, you are dealing with very similar problems. Not to say there aren't some unique problems out there, but for the most part, we're dealing with the same problems, and we have got to stop coming up with solutions independently if someone's already been, solved that problem. And surgeons was its own category, because when you get people in charge of training just on the topic of surgeons, it's great. That's when the language gets sort of spicy. And it's interesting going through this process. There's an initial reticence to discuss the dirty laundry, and to doubt the data. But it's very helpful that, Kaiser can't say, oh no, we've been there. We've been in single-digit percentiles. Well, maybe you have, but not this millennium, okay? But for Intermountain to say, no, we've been there. We've had those same feelings. We've doubted the data at times. We've doubted our ability to make change. And this is how it can be done. I think it's helpful. It's 2 days of really intense problem solving, initiating ideas, building off the ideas of others, discarding ideas. It basically takes what we do over 2 days, 2 or 3 days here in Salt Lake City, where we're always sitting and comparing and saying, oh, you have that problem? Well, this is the way we got around that problem. But really an order of magnitude higher, because when we're interacting here at this meeting, I don't really know your healthcare system, right? I'm just saying, we do it this way. But for the peer visit, you really get to know someone else's system and their roadblocks. And you help them overcome the belief that I think I definitely had in the past of, gosh, we are doing so many things, we have so many sticky notes, we have so much written on so many whiteboards that we must be moving the needle at the end user level, and that's not always the case. And we know this because we round and we speak to your end users, and that's sort of a scary thing to let us do. So kudos to the systems who have been through peer guidance to let us walk around and ask people about their frustrations. And sometimes we've been told around the conference table, no, we don't have a problem in that area. Everything prints just fine when people want it to. And then you go on the wards and you see the workarounds people are doing. Yeah, well, first I send it to my cell phone, and then I bounce it off the satellite, and it eventually makes it to the printer. So obviously workarounds are ubiquitous, and when Diego and I and others, we round at Intermountain, and we see that, yeah, we still have problems that we haven't fixed. But it's a great way to get answers from questions that that have been raised by the data, but class can't necessarily answer because that's where the data ends. You know, that's as granular as we have, but individual users are always a little more granular than that. Next slide. And so we've participated with eSouth Wales. Actually, Dr. Peter Kennedy is somewhere here. There he is in the back.
We put you on the slide. I'm sorry we didn't ask you.
Yeah, sorry. Hopefully your face isn't copyrighted. But and that was an intensely interesting experience. So if you run into someone with an Australian accent in the meeting, it could be Peter. You can ask him questions about the visit. But obviously, based on the feedback we've received, they thought they had gotten a lot out of that. And it certainly was a super interesting experience for us. And I have to thank class for letting Intermountain participate, because we're there to help. And we feel, it's interesting, it's almost not different than the usual doctor-patient relationship I have with people in an ER, but you really do feel obligated to help folks. And so to get feedback that, yeah, we actually did appreciate is very gratifying. And again, it makes us feel very honored to be able to pay it forward this way. And then we have folks somewhere virtually from Indiana University Health who will talk about their experience with the peer guidance program. And I have no idea what they are going to say about their experience with Intermountain and a few others coming to help them work on their scores. So I'll be very interested. Thank you.
Thanks, Doug. Thanks to all of these three. Maybe we give them a hand for what they shared. So thank you so much. Very good. Hopefully we'll have a few minutes at the end here for questions for all, but let me just introduce Dr. Weber and Kelly Wells from Indiana University Health. Very briefly, Dr. Weber is the CMIO at Indiana Health, one of two who've been involved in this project, and Kelly is the VP of Clinical IS Applications. We're extremely engaged, both of them, in both preparing and experiencing the peer guidance visit that we had there. Which was back in September-ish, I think. So, a whole lot of fun to be with them. Again, people with energy who care, much like our Intermountain friends. And so we're excited to hear from them. I'll turn the time over to them, and then when they're done, we'll take questions for the entire group.
Hello.
Hi.
Okay.
Yeah, we can.
Hi, Bob. Hi, Doug. Hi, Chris.
We
Hello,
hear ya.
Class Arch Collaborative meeting. Thanks for letting us share our story. It's great to see you guys again. And yes, this is a trust exercise because they don't know what we're going to say. But spoiler alert, we really enjoyed being part of this experience to share with you as well. So I'm Emily Weber. I'm one of the CMIOs here at IU Health.
And I'm Kelly Wells. I'm the VP for Clinical Apps.
We're coming to you live from beautiful Indianapolis, Indiana, where it is 1,000,000 degrees. And we hope we'll get to join you in person again soon. So as previously mentioned, we're sharing a bit of experience as the recipients of a peer visit. But we are available if you guys need us to go to Australia, wherever you need us to go, we're there for you. And we're just going to share a little bit about what we were hoping to get out of the experience, what our intervention was. We call it our intervention, guys. I hope that's okay. And then what we've been doing since then as a result. So we became part of the peer guidance program as part of an overall effort. We were coming out of COVID like everyone was, and we were needing to really to revamp our whole EHR strategy. So we had kind of a 4-part process that Bob, who was there earlier, and several other folks in our and from class were engaged with. And the peer guidance was one of 4 parts. We were also doing our survey, obviously, as well as visioning sessions and some interviews. But we really wanted to immerse our peers in our environment, and we were hoping to gain some fresh eyes, sort of like what was said before. We really did need that beyond the data, beyond the conference room. And also we need to be able to say it worked, and so that we could kind of get some of that, borrow some of the street cred. Our peer visit was structured with kind of a, we did spend some time in a conference room, and we oriented our visiting team with about a half a day of like who we were as IU Health. Where are we? What do we do? What is our mission to the state and of Indiana and to our citizens? And then we put these guys through what I like to think of as a fun roadshow. And we sent them out all over the state, and they were totally game. We did things like, it was like a fun scavenger hunt. Show up at this time, at this clinic, in this city in Indiana, and someone from IU Health is there to guide you. And I hope you guys had as much fun as we did. We had probably over 50 different IU Health team members get to interact with our peer visiting group and put some miles on that and then reconvene. So of course, this is us. This is across the state of Indiana. In this case, we should have gone first Intermountain because we just have one state on our slide that we're covering. But the fact that we covered it with all of you, we're really grateful for. We have hospitals ranging from critical access to quaternary care. We have clinics, urgent care to resident clinics to learner clinics, a huge range. So we were really glad to have our peers, visitors, have that same perspective of who we're trying to kind of meet the needs for. And here's some, I got no permissions to put these on the slide. So here is just some spots from around, I hope that's okay, some from around the state. And again, the value, I'll just highlight, we've got people, we had activated a new hospital, a whole new regional academic health center that we spent time in. And then we were also in a pediatrics clinic that, decor is a little bit more, late 90s style. We were in our NICU, and you can see we're still masking as well. So really got to cover and meet with a bunch of people. And we did structure it because we wanted to hit some certain venues and talk with some certain groups of people. But for the most part, we really wanted the team to kind of soak it in and then tell us at the end sort of what we could redeploy to. And we had a great time. So we're going to talk about kind of some of our findings and what we've done, but one of the really compelling ones is we'll just call it our True North alignment. I don't have a photo of this, but we walked what we call our production board with this team, in which we have essentially our real clinical portfolio, our applications, our projects, our code upgrades. And this group kind of soaked that in and then reflected back to us that we have a really comprehensive portfolio. But how were we showing and framing this in the eyes of our clinical and team members that were using the tools, and that we needed that? We needed rigor around integrating that and prioritizing that work, because if we didn't, it was not getting done. So I can't emphasize enough how it's a straightforward idea, but to hear it from our peers really gave all of us it wasn't just Kelly and I and our teams being like, pay attention to this. This really resonated with our leaders. So our 3 key areas of focus that were performance and stability, which we are going to talk about in a moment, some of our education, training, and communication. And then we're going to talk a bit about some of these key deliverables that we're doing this year. I am happy to talk with any of you offline, but we do I'd love to hear your questions. So I'll hand it over to Kelly for speed and reliability, which sounds dramatic and exciting.
Oh yeah, super exciting. Well, this was interesting because we had heard a lot about our speed and reliability, particularly our speed, from an area of our organization that tended to complain. So sometimes you take that stuff with a grain of salt, right? You're like, oh, they're always complaining, whatever. So it was very interesting to see a result of our survey, and then to actually sit in that room with these guys and with class and them all say, you know, we don't hear this from other clients. Like, this is not normal. And then it was like, okay, all right, we aren't normal. There is definitely something going on here. So this was really helpful. I mean, you know, it's interesting. I'm in the app side. I'm all about delivery, and I don't get up every morning thinking about, about how we coach or how we, those type of things. But I left this whole thing with so many new ideas of things that I can do in my area and support, how I can support Emily and her peers. So it was great. So like I said, speed and reliability was a problem. And just hearing from others that that this wasn't right was good to know. So, okay, next slide. So we sort of started this layer. We started looking at this layer by layer of what could be causing all these problems. Is it at anywhere from endpoint devices all the way down to the application layer, and putting some big focus in each of the layers to see what we can do. We've always been really good at the application layer and trying to understand like our ATRT and some of those type of things, which is average transaction reaction time. But not as good at the endpoints. I think we had sort of forgotten about our endpoints. We thought they're just boxes out there. They're just bringing out this virtualized environment. Not really the case. So we actually did a VDI new tier 3 sessions that we gave to our physicians. We focused on our physicians because we found our physicians are working very heavily between our EMR and like our PACS system. And so they're pulling up these very large images and things. And so they're getting hit the hardest. And so, we also, another thing we did was bring in Cerner to come and kind of evaluate all of just kind of our setup. Like, are we using the right size devices for the right applications? So that's something I think is developing over time. Okay, so so I mean, at each layer we had some different ideas of things. Another big thing for us is going to the Edge browser components. It's been adding a lot of good movement on our journey. Okay, so yeah, we wanted to we just really started to really realize that if people don't know what's doing what, right? So when they get onto the device, all they care about is it fast? They don't know if it's the computer or if it's the software. So we, we've got to really look at it from the holistic environment. We looked at lots of data to figure out where we needed to go and really spend our time and effort. We wanted to make sure that we were getting out to these folks in a pretty quick cadence. We got the funding we needed to go and replace many of those devices. We actually started to really collaborate better, I think, with our network and endpoint device teams, just to be involved as we go out and do our SWOT assessments, which Emily's going to talk about SWOT a little bit here. But we, definitely saw that our VDI issues, like our number of tickets, were going down. And so here was a great example of two things, I think. First off is we were telling people to restart their sessions a lot. And that was our way of like, that was, okay, nothing's working, just restart. So once we started this, we saw that just the number of restarts we were asking people to do was going down. So kind of a lagging metric of things working. I always like these little comments because, we didn't do much to the EMR. I mean, we did a few things obviously, but everything's faster. Everything's faster. And it had really not that much to do with the EMR and had to do with all the hardware and things that they were working on.
And I think I actually had a story yesterday. I was rounding with some of our new resident physicians, and they said, what's so great is they've replaced this phone. A phone has nothing to do with the EMR, but apparently that phone was accidentally calling 911 because the numbers had worn off. And had we not kind of had this, it's a terrible story, but very compelling about how much we took that to heart about what our people were experiencing, and what you see in the conference room, I think, is true. So we also had some feedback from our visit about how we train, educate, and not just onboard, but after that. And I can see all of you who were part of our peer visit, several of you. So I'm watching your faces to see if this is a vivid memory of how much variation we had. And you're coming to be a doctor here with IU Health, or a nurse, or a pharmacist in an MA, and your experience is so variable because we had kind of an organic an organic portfolio of how we did that, had grown up over time, and it really needed a refresh. It also needed a mechanism post-COVID where we got back out into people's spaces. And so we put together what we fondly call our SWAT team, which is specialized workflows, analytics, and tactics. And that was our moving forward principle. And we did this around the time and informed by our peer visit. And I'm going to show you guys some of this. Since this time, we've done over 1,000 hours since January of coaching. And we have not done our full Arch Collaborative reassessment, but we have done a subset pre and post and seen a much better improvement, turning those boxes green. So this was our guiding principles around the coaching: personalized, specific, and informed by observation as well as data. These were our guiding principles, and I'm seeing some of our colleagues nod because they probably kind of familiar. These are best practices. And we talked a lot about creating space for satisfaction, talking about creating oxygen for that flame of optimism and satisfaction to grow without snuffing it out with lots and lots of other changes, and really solving problems that matter. Our peer visit, I can't say enough great things, because these guys afterwards were responding to my emails and Kelly's and my counterpart, Dr. Schaefer's questions about, well, how do we do this? And a few questions about how much did it cost or not cost, which incredibly compelling to be able to say, someone like us did this and this is the result they saw. So this is kind of our PDSA cycle. The SWATs are how we go in. We spend time in the clinic. We do the entire holistic experience. This is our informatics teams, network, desktop. Everyone goes in and we produce a recommendation. I'm actually, this is one of my favorite things, because we kind of sort them into stuff we can do right now. Stuff that is not really a concern is another bucket, like, and then stuff that's outside the control and scope of our IS team to fix, like things like
we need more
anesthesiologists. Shockingly, Kelly and I can't fix that yet. You know, we'll work on that. But the action and the coaching is a big part of that. And then we continue to do optimization. This is our dashboard and our goals. We're right where we want to be, and you can see there are assessments and where we are. This is a very popular spot to be in. Actually, one of our pediatric neurosurgeons was excited. I didn't tell you this before, but this just happened over this weekend. I said, you're going to get your SWAT in January. And they were pleased, which was very exciting. The SWAT, again, is the first step, and the coaching delivery is the second. And then this is how we measure our outputs. We do our kind of deliverables around time in the EMR. This is a fairly compelling number. This is very real to people, that if we can see what they need to do and learn, these are not changes we have to put into the EMR. This is stuff we already have. It's pretty compelling, because we now are seeing things like, yes, it's good that we finish the work on time, but this is lunch hours reclaimed. This is time with family and exercise, and this is really compelling. Now, everyone's experience is a little bit different, but on average, we're seeing that. And so we are nice and green in that spot. The after hours coaching is the same. And then, like I mentioned, we do a lot of really quick assessments, not what I call the big kahuna survey, but real quick hits. Did this add value to you? Yes or no? Because we need to keep safeguarding that as time, not just for our teams to go out into the space, but for the physicians and clinical team members to take a few minutes, because they kind of gave that up, honestly. During COVID, it was all, and you guys know this, if you work clinically, it's all about doing more in less time. And we really had to start carving out this mastery coaching as not a nice to do, but as a critical part of staying efficient, getting you home on time, getting your work done. We're now in a space where we are starting to coach to some fairly specific deliverables, folks that are really big outliers, people that are spending tons of time afterwards. To be quite honest, people that show up frequently on your delinquent and behind on your records. Instead of that being so punitive, we've been able to kind of pivot our SWAT and coaching to say, that's our people. That's who we go find and meet them where they are. Some fairly pivotal stories that are a little bit beyond this data. We have shown up to do coaching and had people say, I never thought I could learn something new. We've had them say, I thought you were coming to yell at me about my records again. We've had them go from, I don't know, we're pretty welcoming, but that's where we were, just because people hadn't seen someone to come proactively help. And then the other part that and I realize I'm jumping ahead of myself, I'll call out here that I did not fully de-identify this slide. There's some names of our team members, but the names have been protected for the innocent because we learned so much about our people by being in this space. And that's something we took from the peer guidance experience too, is prioritizing being out with our clinical teams that we'd kind of gotten, not that we stopped doing because we just decided not to, we had just prioritized it differently. So by reprioritizing it, we've reclaimed some of that time. I think people are being seen, to be very honest. Like, we get there because of their data, but when we spend time with them, I'll just say, like, I got a very long email that was mostly problems the physician wanted to share with me. But the compelling part was, I can't believe you actually all showed up. Like, I feel heard, I feel seen. And when you show up with this methodology that was kind of informed and inspired by our peer visit, they show up kind of knowing you already. They know that you're where you work and who you are, and it really is quite compelling. So for us, matching that like for like setting, our peer visit, people jumped right in. It was incredibly high value. I also didn't get permission to share this photo, I realize in retrospect. But like, I think that different lens is one that we've carried forward in all of our benchmarking, and our leaders here, our leadership outside of technology, really come to expect. And it's really let us do pretty iterative and frequent actions. Our visit it was in the fall. I believe it's in October, guys. So it's not been that long, and we're really pleased with what we've been able to share already in this short period of time. And that's part of the reason we're virtual, and we appreciate the chance to share with all of you, because we are certainly not resting on our laurels. We intend to keep carrying this forward, and really greatly thank the team that came to be part of our visit. And I hope all of you that are there at the conference see and are inspired as well. It's an incredibly good investment of your time to kind of jumpstart and catalyze some pretty significant change. I think that's it.
So I'm just going to make one brief comment, and then we'll open it up for questions. Peer guidance obviously is something that takes a lot of investment on the part of you and your organization, and not only time and energy, but money. It costs something. It's probably not for everybody. But I did hear a couple of words. I heard intervention, and I heard PTSD. If that's you, it might be the answer. It might be something to help you get over your PTSD, or help have an intervention that might help you move forward. And so it's something we would love to explore with you if it makes sense for your organization. So you can talk to your PSM about that if you have interest or want to explore it. But let's open it up for questions for these folks here that we're involved in, and I can answer from the class side if you need it. Oh, before Peter talks, I just want to say I'm one of the only ones who didn't get to go to Australia, so apparently I have too much of a Western accent. But
Peter Kennedy, I'm from Sydney, and eHealth New South Wales is part of the public health system there. We look after 8 million people in the public health system. We have 180,000 staff and 220 or 230 hospitals, and then a variety of different clinics. We're in the middle of a procurement process. We're 85% Cerner. We've actually made a decision to have Epic as the preferred vendor, but we haven't signed a contract. And all this was happening with COVID at the same time as we got our first class survey, which wasn't great, wasn't as bad as Intermountain. So that's a good thing. And we decided we talked to class, and we talked about this peer guidance process. It took quite a lot to arrange, and getting everybody out there. It was more a peer guidance week, I guess. But it was fabulous. It's been great for us. The first thing I say is that the peers were fabulous. We had 2 of the people on stage there. We had Kathy and Mike, and we also had Rachel from the NHS. The second thing is I was surprised how accurate rounding was, reflecting the real issues on the ground and the value of rounding. And if you can managed to do that in your own sites, it would be fabulous, because I thought, what, they're going out for only an hour or two, and they got so much information. Because of the COVID issues, it was a bit difficult for us to organise a lot of it at the time, but it was such a great value. The second thing was that we got all these people from overseas that knew a lot about EMR to come and talk to us after 2 or 3 years when we'd had COVID. None of us left the country except me, because I came across to the CLAS conference last year to sort of finalise the peer-to-peer process. Secondly, was working with the CLAS team. Chris Clune and Jeremy Goff and others was excellent, and they supported us through the whole process. The value for us was getting everybody in a room with experts talking about what they knew, and allowing access for our staff to have that expertise in Australia at the same time. It's actually much cheaper for us to pay a relatively reasonable amount of money to get the peers out there than try and find and send 100 people over to here. So it was good value in return, but it's also focused our minds on our issues, validated what we knew, and it's given us, I think, a vision for what we have to do as we implement what will be one of the largest EPIC sites in the world when we do over a period of 4 or 5 years, which we hope to be starting to do late this year, early next year. So if anyone wanted to talk to me about what I thought, I'm quite happy to do it, but we found it a really valuable valuable time, and people are still talking about the Peer Guidance Week and the value we've got out of it. So I thank CLAS and the peers for what they did, but it was a very, very valuable process. Thank you,
Peter. Any specific questions for any of the individuals up here?
I'll throw it out in general. I was wondering, in your peer evaluations, what experience have you been giving folks around handling places that have a large number of non-employed physicians that don't have similar structures that are easy to get to? Is there any difference in the way that you treat them, or do you just group them as the concept of a medical staff and try to treat them all the same?
It's a good Intermountain question. So,
the bulk of providers who use our EHR within the Intermountain system, the bulk of the physicians are not employed by Intermountain, and we still have to reach them, and they may not be checking their Intermountain mail. So certainly you do have a certain more enhanced route of communication when you have an employer-employee relationship. But these are the providers that we have to communicate with and convince them to receive coaching and be highly satisfied. But I think there's a way to market what we do to those folks. I mean, I look at University of Utah physicians and say, Intermountain is spending a lot of money on you to offer you this coaching, and you should take this coaching. And it doesn't matter at the Children's Hospital that a lot of the providers work for the U of U. That's not stood in the way of the kind of interventions, some of the ones that Chris discussed. The work just still moves forward, even though they're not actually employees of the company who owns the hospital. You want to add anything?
Yeah, I was going to say, if the focus, maybe from the lens of coaching and how you convince providers who aren't employed to coach, we didn't require, I don't think, any providers. Maybe there was a little bit of coercion depending upon the specialty, but we didn't require it as part of education. We were really selling it on the value, because we weren't compensating them for it either. It was, here is something that we're offering you as a service, and here's what your peers have said about it. This is only going to take 30, 60 minutes of your time, whatever you want it to be, and here's the value that people who work in the same roles that you work in have said about it. Would you consider it? And I think it was harder early on, and now it has a reputation that we don't have to do an awful lot of convincing. It's just accepted as a thing that's going to improve experiences. Anything you'd add, Chris?
The only thing I would add is one of our trauma hospitals, I remember meeting with their medical director, and he was talking about how great the program is and how much it's helped and the challenges with affiliates, and thinking like, hey, should we put this in the bylaws of their credentialing, that it's required to do a refresher course every 2 years? And we kind of sat there like, wow, I don't know if we're ready for that type of volume. Can we manage that volume if you're putting it in and requiring it? And we'd have to give them a certificate that they participated. And his feedback was, this is a tool they're using 30 or 40% of their time in our hospitals. There's so many updates. We want them using it safely. It seems reasonable to require to practice in our facilities a certain level of education. So that's something that we've explored with the affiliated space, because you do have to get creative. There's just not the levers you can pull like there are with employed. But overall, the concept engagement's been really good, especially with onboarding and coaching new affiliated physicians, at a week or at 30 or 60 days for like a wellness check. We've been able to have a lot of success with the affiliated space in that area. It's the reoccurring that I think we could continue to improve.
Dr. Weber or Kelly, anything you'd add?
Oh, there.
You're on mute if you're talking, Dr. Weber.
We are nodding in agreement about
Okay.
creating the value and also making it part of what you expect.
Okay.
So, sorry, we were agreeing.
Okay, awesome. We have time probably for one more question, and then, because we're in the way of lunch, so we can't go too long. Yeah. Yes. Right up here.
Wait just a minute.
She'll bring a mic.
Thank you for the stories. They're absolutely fantastic and completely inspiring to hear how we, as colleagues, we can help each other. What I haven't gotten that I'm really kind of wanting to hear are the details. I mean, do you all just go someplace for a week, round, come up with a bunch of conclusions, sit down and say, here's what you should do, 1, 2, 3, 4, and leave? I mean, there's prep work, there's afterward follow-up. How do you decide what you're going to prioritize? How do you decide who you're going to round with? I mean, can you give a little bit more
So you're talking
in the
about
weeds on this?
during the peer visit or post-peer visit or both?
The whole process. I mean, somebody comes to you today and says, I want to participate in this peer process program. What happens next?
Yeah. So I can do the first part, and then you guys can do guys can do what you did with the data, because frankly, the heavy work is after we leave, right? But there's a lot of great insights and information that can be given you to help create that plan, right? So step one is, how do we help you understand where your blind spots are is really what, and I actually heard that from both these organizations, where your blind spots are. The peers can come in and say, totally unbiased, independent thinkers saying, I think you're not focused on the right thing. So the structure of that visit, it was a day and a half to 2 or 3 days when you travel all the way to Australia, but usually a day and a half to 2 days, where we really are learning about your organization, the peers and class, understanding your data, understanding your structure, understanding your governance. And so it's a dog and pony show for a little while. We need to know what it is that you are. And some of that we can do before, but a lot of it, it's just different when you're there together in the room and learning together. Then we go out and visit and go to multiple sites, as was mentioned at Indiana Health University. Those are probably the funnest part of the whole experience. Not that being with the others isn't fun. And then you come back together. We have time to assimilate the findings from that experience and from what we learned during the in-room sessions, and bring back a recommendation, 30, 60, 90-day plan that you might address in the areas that you saw some of these things put up there. And so that's really the peer guidance visit. That's the visit. And then there's follow-up at the 30, 60, 90-day mark to just kind of say, how's it coming? But we're really just holding you accountable. It's your plan. So then I'm going to turn it to these guys. They both talked a little bit about what they received in terms of counsel and guidance, and then what they did with it after that they can talk to. Did you want to say something, Kathy? After that. Okay. Okay.
Well, I didn't know if anyone.
Yeah, let's go. Emily, do you want to go first? What happened after we left? How did you make it a plan?
No, and I want to be respectful of your lunch, but to the commentator, thank you so much for that. I think the delivery of the recommendations, to be super honest, it kind of evolved, because we're like, here's what we're asking, here's what we want. And then there were some very pragmatic small details that our team gave us. But then we set the expectation that this was going to be, I'm a pediatrician. I didn't say that at the beginning, but this was my consult. This was my consult for my satisfaction that was a code, and I wanted the recommendations to be acted on. So the delivery of those details were a bit of benchmark, a bit of action oriented, but then it was really up to us about how we do that next. And this team knows, like, it wasn't about let's wait to do something until we get this bucket of money or that happens or whatever. We kind of just went. And I think I highly recommend that. Be ready to start doing iterative improvements and be thinking in that way.
Yeah, I think it began with an awful lot of learning about the organization and the scores, and then getting on site and hearing about how that organization is looking at their scores and what their focal points are and what strategies they're already thinking about and how they're approaching it. And maybe if I'm sharing something that I think I'm okay to share, for when we were receiving peer guidance, one of those things was like, well, we know we need to communicate better. We're going to create better communication plans. And the question was, well, like, what does that mean? Like, what do you mean you're going to create better communication plans? And we'd lay that out and say, and then those would be criticized, and it was a great criticism. Another one that really stood out to me, Kathy gave it to me, actually. We were talking about coaching programs, about building the mastery program, and she asked, well, how are you going to lift your people up? How are you going to develop them? How are you going to build coaches? And that seems so obvious, but I don't know, we're just going to get them out there and they're going to do it. They're smart, they'll figure it out. We hadn't spent enough time thinking about that, but for me it was, we have these plans, we need an outsider to help us pick apart what we haven't thought about yet, or in sometimes to refocus them in a different direction that we couldn't see from within the problem.
So it feels like we're being pushed out, but if you want
Bob, I
quickly.
just
We'll
wanted
have
to
to
say
talk more.
quickly, this is Kathy Potere, formerly with Kaiser Permanente Northwest. I've now graduated from work, but I've been doing a little consulting work with these folks and others. But I just wanted to say one of the points that the IU folks and Intermountain and Peter and his group didn't say is that we went into very well prepared and engaged teams. One of the common elements was they had accepted the truth in some way about what they were doing, but the exact strategies and tactics weren't clear. And I think that's where it was a very shared experience in hearing about them and saying, what would we do if we were in your shoes? So it's just really so I would say we had very engaged teams, very wonderful, hardworking groups that wanted things to be a little different than they were prior to us walking in. And the class team too, so there's a lot of prep. I will say, from doing a lot of these events myself, to answer your question, there's a lot of prep in advance to coordinate the visits, to go meet, to let those that we're visiting out in the hospitals and clinics know that strangers are coming, that we're safe. And we had, in all instances, we had people that were very open to us being there and sharing their true experience and feeling trust for their leaders, that they weren't going to hurt their feelings. So I'll leave it with that.
Thank you. So in addition to those that are on this stage here, if Kathy, Mike, and David would stand, these three were also peers. So if you're looking for somebody to talk to about this, you can talk to them as well, along with our Intermountain folks. So you'd be welcome to talk to any of them and anybody at class. So thank you for your attention. We'd love to talk more about it if you're interested. Enjoy your lunch.